Oh.
Okay, if we can get started. Today's lecture is presented by Dr. Neri, a pediatrician in the Department of Pediatrics. She's going to be talking about the respiratory viruses and gastrointestinal viruses. Those of you that are going to go into pediatrics are definitely going to see these. Those of you that have children will definitely see these viruses.
Thank you. That is very true. And those of you who have already seen this will recognize what I'm talking about when we get to it. But I'm going to start with the respiratory viruses today. And we have a lot of material to cover between the two lectures. And I don't want to go out over time, so I may zip through a few parts. But please interrupt with questions if you have them as we go along. Don't save them till the end. And also, I am going to try and give you a real-life clinical perspective and give you the emphasis and the clinical correlations. There is a lot more of text material that you will have to cover reading on your own. But if you're auditory learners, listen. This is a good time. If you're visual learners, pay attention to the slides. But everything that I'm covering that's important is in your handouts and in your slides. But what I want you to listen and take from here today is the clinical correlation, the emphasis, and how it's important. So I'm going to start out with the paramyxoviruses. And this is kind of a broad outline on how we're going to approach the issue of, or the big topic of paramyxoviruses. But first I'm going to go into the class and tell you about the features. Now, you have already done the influenza virus recently with Dr. Hunt and learned about that in great detail, which is, of course, a very clinically important virus. And so this is kind of a cousin of the orthomyxovirus or influenza virus called paramyxoviruses. And similar to influenza, these are also respiratory pathogens. They are enveloped RNA viruses. And the classification goes into subfamily pneumovirinae and paramyxovirus over here. Right here. And we have the three genera, paramyxovirus, rubella and morbillivirus. You may recognize some of these names because you have done pathogens from these genera before. And these share the property of a hemagglutinin neuraminidase HN protein. Whereas the subfamily pneumovirinae, of which the chief member here is in the genus pneumovirus, the RSV virus, which we're going to talk about in great detail later on, and the newer added genus metapneumovirus, human metapneumovirus, of which is the chief pathogen that we know a lot about now, does not contain the HN activity protein, contains the G protein instead. So a little difference between the two families. Now let's talk about the genus paramyxovirus, of which the important pathogens are parainfluenza virus, PIV number 1 and 3. Again, we're talking chiefly about human pathogens here, knowing that there is a similar pathogen called the Sendai virus in mice. And it's interesting that when we know there's an animal pathogen that's related to the human pathogen, it gives us a lot of opportunity to use that for experimental studies, knowing that there's some relatedness between these two. Going on to the genus rubella virus, have you done mumps virus yet? Or are you have done that, so you know some of the features. Again, genus rubella virus also contains the parainfluenza viruses 2 and 4. And finally, the measles virus is the important member of the genus morbillivirus, morbilli coming from that type of rash that comes with measles. And then a related dog virus called the canine distemper virus. If anyone of you have dog pets, you would have heard about this because it's important. Okay, let's move on into, let me skip. Oops, did I go back? Okay. I'm sorry? Yeah. No, it has shifted around. If that's the case, it sometimes does that on the writing. Let me go through it right here. Let's see here. You know what? This has shifted around. That is a good point. We need to get that straightened out. me see here. I'll get back here to this line here. Yeah, we have morbillivirus, rubella virus. Huh, that's interesting. That should be, yeah, that should be corrected. Okay, we'll get that done. Okay, structural features. These are fairly large viruses. Look at that size over there, 150 to 300 nanometers. They're pleomorphic in that they can have different shapes, not a definite set spherical shape. And as we will talk about later, these are envelope viruses. The genome is contained in the nucleocapsid, which has RNA associated with 3 proteins here: nucleoprotein, phosphoprotein P, and large protein, which is L. And the genome is kind of coiled up within the envelope of the virus. And let's take a look at this picture here where you see the envelope here, and then inside here is, inside the nucleocapsid, you have the genome, which is actually protruding from this particular disrupted virus, and it is basically the coiled kind of helical, twisted, coiled, whatever you may call it, kind of genome here. And look at the size bar there telling you that these are about 300 nanometers large. Talking about the structure again, as you know, envelope viruses have the typical lipid bilayer, and this lipid bilayer is important for its antigenic and attachment properties. And within these are certain virus-specific glycoproteins that kind of sit in there. In addition, you have the HN protein, which is present in these paramyxoviruses, which is important for conferring the property of heme adsorption, hemagglutination, and also acts as a viral attachment protein. First step in the pathogenesis of viral infections is the attachment. And interestingly, F protein, or fusion protein, which is important in the fusion and coalescence of infected cells, and that is called the F protein. It has some importance in terms of vaccine and immunity. We'll talk about that later. The schematic diagram here about the spherical or spheroid virus with the lipid bilayer on the outside, with the spikes of the viral protein, F protein, and depending on the type, HN, H, or G glycoprotein spikes. And then within that, you have an M protein, which is on the inside. And then in the core, you have the nucleoprotein, which is the RNA in this case, coiled up with the associated proteins that we talked about. Again, a larger picture in detail to show you what we were just talking about. I'm going to go over to the M protein, which we mentioned and talked about, is located inside the envelope. It's important assembly, and the core contains the the nucleoprotein and phosphoprotein large protein. Again, a schematic of the same thing. And now we want to talk about why is this an important pathogen. It is very prevalent, it is highly infectious, and can survive on surfaces like right here, And that can help in the transmission of infection. But it is not as hardy as we think in that sense, because it can be destroyed by simple disinfectant, soap and water. This property seems to be pretty common with envelope viruses. And certain unique properties of paramyxoviruses, and I think you've studied about orthomyxoviruses also, is that they are heme-adsorbing viruses. And unlike the influenza virus, which shows antigenic shifts and drifts, etc., this is fairly antigenically stable. Now, moving on to the actual pathogenesis of infection, as I mentioned, the first step is the attachment. And for those, the 2 proteins are important here, the F protein and the HN protein. The first thing to understand is that these are respiratory viruses, so they tend to attach to the respiratory mucosae. And the first one up here is on the upper tract, is the nasopharyngeal mucosa. Some similar mucosa is present in the lower respiratory tract, and so they kind of march along, climb down from the upper tract to the lower tract in a few days. And at a cellular level, once the virus attaches to the susceptible host cell, there's uncoating of the virus, entry into the cytoplasm, and then following that, the actual replication of the virus takes place. And I do not want to go into a whole lot of details of viral replication because I think that has been covered in a lot of detail elsewhere. So just to say that the virus does replicate in the cytoplasm, forming copies of the proteins and the genome it needs, and finally it's assembled and out of the cell by budding, and before that it acquires an envelope, because these are envelope viruses, and the glycoproteins kind of stick into that envelope as well. Now, these are such important viruses that they are really present everywhere around the world and very, very widespread, and most people have had some sort of infection. Whether it has been a clinical infection or a subclinical infection, everyone has had or had a taste of parainfluenza virus before they've turned 5. And this is pretty universal around the world. Now, in terms of the specific times when we see, this is exactly the time of year that we start to see parainfluenza viruses. And we see them in early fall, late fall, early winter, exactly where we're at right now. And the 1 and 2 types seem to be the predominant ones that we see a lot more infection due to, not to say that the others don't cause infections. And these are highly transmissible through respiratory droplets and aerosols, and again, through inanimate surfaces where droplets land on, say, a solid surface, and then someone picks it up through their hands, ends up into the mouth or nasal cavity, and then sets up infection. So this is to not underestimate the power of a sneeze, and this just shows you how many droplets are generated, and each of these can be infectious droplets that can either land directly on susceptible surfaces or on inanimate objects and surfaces, and then can spread the virus. So really, droplet transmission can be pretty effective in respiratory viruses. And the other thing that's interesting is that even though people have seen the infection, primary infection under the age of 5, reinfections do occur because the immunity is not perfect. And so therefore, people may have reinfections that are so mild that they may even not have symptoms. But because they are infected, they remain transmitters of the virus. And so the viral shedding that occurs before symptoms and after the infection continues to cause outbreaks in the community. And people who are immunocompromised, who don't have that great immune system to limit the virus infection, they tend to show larger titers of virus and shed for longer times. So this slide is basically to tell you the epidemiologic importance in terms of viral infections. This is very true, more so than bacterial infections, because the number of classical clinically apparent cases is just the tip of the iceberg. It is the smallest fraction of cases that actually you are aware of. Mild clinical cases where people are going about their business of daily life, not really complaining that they're sick even, oh, my throat hurts a little bit, they are kind of a larger proportion, and the largest proportion, probably 80 to 90%, are these people who are asymptomatic and are shedding the virus and thereby transmitting it. So remember, with viral infections, what is clinically apparent is just the tip of the iceberg. And this is for parainfluenza type 1. The CDC seems to keep these figures and updates them every year. So the data for last year show that fall into early winter, you see this peak of virus activity in terms of antigen detection and viral isolation. And for the rest of the year, you don't see a whole lot, maybe small numbers. So this is important to demonstrate the seasonality of the viruses. The same information for parainfluenza type 2. Now, type 1 and type 2, the type 1 seems to take predominance one year, and the type 2 seems to kind of sit back and let the other one do its job. And so this past year, you didn't have a whole lot of parainfluenza type 2 virus activity during the similar times of year. Now, parainfluenza type 3, interestingly, look at this. This is around early summer. And so you see a little blip of activity here, not so much in the fall and winter, again, summer. So that's interesting epidemiologic description. Going on to clinical features now, you know that this is a respiratory pathogen entering through the mucosa there. Short incubation period of under a week. And again, the whole spectrum of asymptomatic to symptomatic cases. We'll talk about the specific types of symptoms over here. And then if you're an adult and you've had the infection before and you're going through a secondary infection or reinfection, your symptoms are going to be much milder. So let's go over the respiratory symptoms due to parainfluenza viruses. The first one here that shows you a chest X-ray from a case of parainfluenza pneumonia, where you see these kind of streaky infiltrates bilateral, which does not fit the radiological picture of a of a bacterial pneumonia. So it's not lobar, it's more streaky and generalized, and that's a case of viral pneumonia. But looking at the upper to lower tract involvement, we have just mild cases with upper respiratory infection, scratchy throat, pharyngitis. But when we go into this unique syndrome called croup, which is called acute laryngotracheobronchitis, which tells you involvement of the larynx, the trachea, and the bronchi. And this is a syndrome which is seen mainly in pediatric cases, children under 6 years of age. And it basically presents with fever, cough, hoarseness, and then into the stage of respiratory distress, where there is difficulty in breathing with an inspiratory sound. And interestingly, there are demonstrations of this that are on the internet with, they can play the sounds with stridor, but it kind of makes the sounds like, it does not sound nice. It scares the heck out of the parents. What's going on here? And it really tells you and shows you that the child is very uncomfortable. And this is just to review the anatomy of the upper tract. You have the nasopharynx here going down into the epiglottis here, which is kind of gatekeeper here near the airway. And then you go into the actual larynx, and this subglottic area, which is between the epiglottis and larynx, this is where a lot of inflammation happens in croup. And we'll show you exactly how that shows up in the radiographs. But then going down the larynx into the lower respiratory tract, you have the trachea, the larger bronchi, etc. So here's a radiograph in a case of croup where you see where the glottic opening is here is normally narrow in kids, but when there's mucosal edema with croup, it gets into a pretty narrow little pipe here. It can be as narrow as a straw, and that makes the work of breathing much harder. And so radiologically, this appearance, which doesn't project so well here, of a tapered, area of the airway column here has been called a pencil or steeple sign sometimes, but it just tells you that there is narrowing in the subglottic area. So with croup, you see the seasonality, where you see it in fall to early winter, not to say that you can have cases right in the middle of January and February, but the seasonal cases are usually caused by these two strains kind of alternating years. And in between a few cases, especially like non-fall-winter cases like we saw in the summer, seasonality can be caused by parainfluenza type 3. So when you have a case of croup, you don't have a whole lot of options in terms of antiviral therapy because it doesn't seem to do a lot of clinical good. What really helps is to make the work of breathing easier. And for this, the humidification of the air and shrinking the mucosa with racemic epinephrine, which basically is a vasoconstrictor. And in some cases, they have used steroids, and these could be, first they tried inhaled steroids, then they tried subcutaneous or intramuscular, and then PO steroids in different forms, basically to shrink the airway mucosa. And once the viral infection is under control because of host defenses, then the work of breathing gets better by itself. We talked about parainfluenza type 3 infections, which show a different kind of seasonality, but they cause a similar spectrum of disease in children. And in fact, I have a picture here of a child with parainfluenza type 3 pneumonia that was confirmed by viral culture that had this kind of X-ray picture, and I'm not sure if it projects very well, but quite impressive streaky infiltrates here, especially on the right side. This child had high fevers, 103, 104 for about 5 days, with very predominant respiratory symptoms during this time, and no bacterial pathogen was isolated from him. Finally, several days later, the viral culture was positive. Here you see the lateral view showing some fluid in the fissure. There's a lot of inflammation down in the lungs, and that's clinically manifest by the lower respiratory tract symptoms. Type 4 infections are less important from a epidemiologic perspective, but do occur. They're milder, and when they occur, they usually tend to involve mainly the upper airway, not so much pneumonia and lower airway. Now, what do we do to diagnose these infections? It would be nice if we could culture the virus from everyone, but these are labile viruses, and therefore the virus, if the technique is not right, the virus may not be recovered through viral culture. So the mainstay that we use is antigen detection, and that is quicker and easier to do with a rapid turnaround time as well. And you use direct nasopharyngeal secretions. You can also use tracheal secretions if you suspect pneumonia. And the methods used are DFA and ELISA. Now, the viral culture is possible, and in reference labs, this is done through these cell lines. And then you look for cytopathic effect within 3 to 4 days. And if you do see that cytopathic effect, you go ahead and look for the direct probes to give you the serotype. And if it's negative, what they do is they do a blind pass and then let it grow again and then repeat the check for cytopathic effect and then look at the specific of which type it could be. Serology for viruses is quite limited because there's a lot of background positivity. A lot of people are immune to the virus or show serologic immunity because the virus has infected them before. So only demonstration of a fourfold change in those antibody titers can be significant for acute infection. Now, PCR techniques are gaining popularity all over the world because they are very sensitive. And they're not as easy to do, but they do give you a rapid answer. So, bottom line is, how do we prevent these infections? They are very prevalent, they're ubiquitous, we're exposed to them every day pretty much. And so what do you do to protect yourself? So, hand washing is a good technique. It's easy, it's cheap, easily available. And there is a role for the hand sanitizer gels here, which you see as Purell and all, and these are good for disrupting the virus since these are envelope viruses. And important that we use a lot of surfaces day to day. You use computer keyboards, a lot of surfaces to prevent these from getting contaminated in a hospital setting. And also if they do get contaminated, to avoid yourself inoculating it into the mucosa. So these are some of the key features of parainfluenza viruses, and now I'm going to go on to RSV, which is the next important pathogen. But if there are any questions or clarifications here, I just want to stop for a minute.